This video is for patients who want to learn more about meniscal root tears, including an arthroscopic demonstration of surgical repair. Meniscal root tears occur where the meniscus attaches to the tibia bone. These injuries are often associated with trauma, but they can occur over time due to normal wear and tear on the knee, especially in those patients with osteoarthritis. The symptoms of a meniscus root tear include swelling, pain in the knee, feelings of locking, catching, or giving way. If the history or the physical examination are suspicious for a possible meniscus root tear, we order an MRI to confirm the diagnosis. Each knee has two sets of meniscus tissue, one on the inside and another on the outside. These are C-shaped cartilage rings that serve as shock absorbers between the femur and the tibia bone. In this image, they are represented as pink. Meniscus tears come in all different shapes and sizes. Sometimes we are able to simply trim out the torn tissue, which is referred to as a meniscectomy, and other times, if the tear is within the substance of the tissue, a repair is performed with sutures. A root tear is a unique type of meniscus tear. These tears occur at the attachment site of the meniscus to the tibia bone, which we refer to as the root. When these tear from the bone, as can happen in the back or the posterior aspect of the medial meniscus, a meniscectomy is not appropriate. Hence, a special type of meniscus repair, a root repair, can be performed in these cases. These images are slices from an MRI performed of the knee. They show a gap in the posterior aspect that is filled with fluid. In these images, the normal meniscal tissue is black while the fluid appears white. The white arrow indicates the region of the root tear. This white appearance is termed the ghost sign because of the lack of meniscal tissue at this attachment site. This was a 54-year-old male with a medial meniscal root tear. I approached these arthroscopically, so here with the probe, I can displace the torn meniscus tissue from the very back of the knee. The remainder of the meniscus looks very normal. There is a little bit of early arthritis on the femur. I then take the shaver and then a tool called a curette to basically remove the cartilage from the footprint area where the meniscus would attach to create a healthy bleeding surface once the repair is completed so that the meniscal tissue can heal back down to the bone. Once that is prepared, I then insert a guide into the knee arthroscopically, and this guide is able to hook over the posterior aspect of the tibia to allow me to place a guide pin right in that footprint of the meniscus. Once I'm happy with my position of the guide pin, which is seen here, I actually remove the guide pin and then a reamer is placed, and this reamer allows me to create a small socket at the footprint, again to help with bleeding tissue for a secure repair. Once I clear out all the debris from that work with the shaver, a tool called a scorpion is introduced, and this is able to pass a non-absorbable suture that has a self-locking loop on it, so I can get a good bite of that tissue as seen here. That stitch was passed more medially, and then I pass a second stitch here laterally through the base of the meniscus just adjacent to the root. Those sutures are tightened, and as you can see, they're secured upon themselves. I then pass another suture up through the tunnel that was created on the tibia. That blue suture is retrieved here, and that suture then allows me to shuttle the looped sutures through the base of the meniscal root into the tibia. And you can see now that with tension applied, with probing, that meniscus root is completely stable and secured to the tibia. Overall, there are good clinical outcomes reported for meniscal root repair when performed in the proper patient. In our clinic, radiographs, physical examination, history, and MRI all help to make that decision. Several factors are associated with poorer outcomes, including obesity, the presence of more moderate to severe arthritis of the knee, as well as a bow-legged shape to the leg. There is data to suggest that if left untreated, a meniscal root tear can increase the risk of osteoarthritis due to a lack of effective transfer of stress by the meniscus and increased forces between the cartilage on the femur and tibia. Rehabilitation after meniscal root repair consists of protecting the repair with toe-touch weight bearing for 6 weeks. Patients are followed by a physical therapist immediately to begin working on quadriceps activation, mobilization of the knee, and range of motion. In the second phase, we seek to achieve normal gait and full weight bearing while progressing knee flexion and the ability to achieve full weight bearing with a normal gait. Rehabilitation after this focuses on regaining strength and endurance exercises such as running can take up to 5 to 7 months before returning to normal.